Mechanical ventilation plays a big role in the management of in the ICU. Ventilatory failure. Mechanical ventilation is a valuable modality for patients who are unable to maintain the appropriate level of ventilation to preserve gas exchange functions, both oxygenation and carbon dioxide elimination. Patients who require artificial breathing, regardless of their diagnosis or illness state, have often suffer ventilatory failure, oxygenation failure, or even both of them, and not supply the oxygen needed for metabolism due to increase in the work of breathing. So these are some of the goals of mechanical ventilation. The first one is to improve gaseous exchange, and our target is to reverse hypoxemia and relieve the acute respiratory acidosis. The second one is to relieve respiratory distress, which our target is to reduce the oxygen cost of breathing and also reverse the respiratory muscle fatigue. The third goal is to improve pulmonary mechanics, which targets include to prevent and reverse atelectasis, improve lung compliance, and prevent lung injury. Our fourth goal is to permit lung and airway healing, thereby maintaining lung and airway functions. And then the last goal is to avoid complications. This has been some of the evolution of mechanical ventilation, the ventilation phases and sequential therapy, from oxygen therapy to non-invasive ventilation to invasive ventilation, then we step down to non-invasive ventilation, and then oxygen therapy. The phases are from prevention phase to stabilize, weaning phase, and then the recovery phase. Types of mechanical nasal mask and helmets. The mode of ventilation actually is determined by the machine, how they ventilate the patient, and how much the patient will participate in his own ventilatory pattern. Each mode is reduced risk of ventilator-acquired pneumonia, and also reduce mortality and morbidity and respiratory failure. There are some contraindications that are absolute, such as patients that are already having respiratory arrest or patients that are not stable. And those patients that have craniofacial or trauma burns, we can't apply it. While some of the relative contraindications include morbid obesity, uncooperative patients. These are some of the requirements for the successful non-invasive. Patient must be cooperative. Then there are supplements which include high flow oxygen therapy. It can be used for hypercapnic respiratory failure, hypoxemic respiratory failure, post-extubation, pre-extubation oxygenation, and patients with sleep apnea. This is a picture trying to demonstrate the high flow oxygen therapy. Then we compare low flow oxygen therapy to high flow oxygen therapy. The flow for the low flow can be between 2 to 15 liters, while for the high flow it can be as high as 80 liters per minute. For oxygen concentration in low flow is less than 80%, while for high flow it can be up to 100% oxygen concentration. These are some of the clinical benefits of low flow oxygen. It corrects hypoxemia, it decreased dead space, it improves patient comfort, and is optimal for warming and humidifying. This is just a picture trying to show the entrance of oxygen therapy by the new machine SV300. The trend of monitor oxygen flow and also the flow range, which can be as high as 2 to 50 liters per minute. It will give you real value of the delivered flow, and some of the side effects of oxygen include oxygen poisoning, absorption atelectasis, and then some of the contraindications. We have some ventilatory modes in non-invasive ventilation. We include the CPAP, BiPAP, pressure support ventilation, pressure control, and APRV. There are some criteria for terminating non-invasive, and then you have to switch to invasive. When there is worsening of the pH and PCO2, when there is tachycardia, when the SpO2 remains less than 90%, or when there is decreased level of consciousness, you have to switch to mechanical invasive ventilation. For invasive mechanical ventilation, it's always through an endotracheal tube, or sometimes it can be through a tracheostomy tube, and is a definitive intervention to ensure adequate oxygenation and ventilation. We have different modes of invasive ventilation: CLV, IPPV, SIMD. We also have the one with dual modes. This is just a summary of ventilation modes. The aim is to control, then lead to cycle, expiration, then trigger. For volume assist control ventilation mode, a certain tidal volume is delivered to the patient within a certain period of gas delivery time. The clinical use include there will be no spontaneous breathing. You need to control the tidal volume, and then airway resistance is too high to ventilate the patient. This is the pressure assist control ventilation mode, where the patient's airway pressure rises to meet the preset pressure level within the time of pressure rising. It can be used in patients that have no spontaneous breathing. Also, pediatric patients benefit from it. Then we have the pressure support ventilation mode. This system delivers it when it detects that the patient's inspiratory effort actually reaches the preset inspiratory trigger value. And these are some of the advantages. It has a good machine-human synchronization, and it's also benefit, especially when weaning off ventilator. So, which of the parameters is required to be set? For this one, we set the FiO2, set the support pressure, set the pressure rising time, and the inspiratory time. And this is just a pictorial diagram trying to show the pressure regulated but volume control ventilation mode, which is a relatively low pressure level, is held as much as high, especially during the inspiratory phase, to guarantee our preset tidal volume. The benefit of this is that it has a constant tidal volume that targets ventilation. It has decelerating waveform, which facilitates reopening of the collapsed alveolar and hence improve oxygenation. It also has automatic compensation in case of air leakage, and there's reduced alarms, which can actually reduce the workload for the ICU staff. For SIMD, is designed to guarantee minimum ventilation frequency within the trigger mode. Some of the advantages is improve the asynchrony between the man and the machine, and it's also a mode for weaning. For airway pressure release ventilation, this can be seen as a periodical short period airway pressure release in CPAP mode. There is no pressure support ventilation in both high and low pressure, and is a special ventilation mode specially used for the treatment of severe ARDS. For the dual level positive airway pressure ventilation, this system alternates between adjusting both the pressure levels of continuous positive airway pressure. At low pressure, what is done is that the pressure support can be set, and there is always transition between high and low pressure, which is controlled by the trigger window. So, what do you choose? How to set depends on the patient's condition. For adaptive minute ventilation mode, is an easy mode, is a new mode, and is based on the widely recognized authorized minimum breathing work principle. There is auto adjust of the settings, and you only need to set just the minute volume, the PEEP, and the FiO2. There is an auto switch, which switch between the different modes. The uniqueness of this mode is that there are fewer settings, there is reduced workload for medical staff, there is no need to change modules during the entire mechanical ventilation process, and the patient's comfort. This is how it works. It's always switching between modes. Which mode of ventilation is suitable for this current patient, and then you switch to it. So that's how you just enter the AMV mode interface and select patient set, height, weight system, and it automatically calculates what to give the patient. Okay. In conclusion, mechanical ventilator is life-saving, but in inexperienced hands, the contrary is the outcome. A good understanding of various modes will also go a long way. Without contraindication, non-invasive is becoming the first modality now to try in many settings, and it's when patient is getting worse or not getting better that you can now do the invasive one. And also, the non-invasive can be employed outside the ICU, making it more preferable for people to use. Thank you very much. The migrant stand is outside. You can check up on the CM 300, the new machine. Thank you.
Okay. morning. I would like just to share a secret with you that it took me 22 hours to fly from Dubai, traveling to reach here. And it's a pleasure, to meet you and to be with you today. My name is Mohammed Alaouni. I'm Director of Clinical Education with GE Healthcare. We are based in Dubai and we are covering the region of Middle East, Africa, Turkey, and Central Asia. Okay, so the topic we will share with you today is about adequacy of anesthesia. While we are talking to anesthesiologists and in Anesthesia Congress, I believe that we would like to share with you the tools that may help you during, putting your patient to sleep, anesthetize him safely, and make sure that you deliver a tailored therapy. Can we change to next, please? It's not working. Okay. So, we would like to reflect on COVID and pandemic. It was bad. The good thing, you were the heroes and you did a great job. But COVID opened our eyes on something good, that we need a solution. So when we talk about peri-op care area, we need a complete solution. With GE Healthcare, we have the full solution from gas delivery to monitoring. And when we talk about monitoring here, we talk about respiratory monitoring, hemodynamics, cardiac, neurology, and one of the special ones for OR or anesthesia is adequacy of anesthesia. In addition to that, we have the ultrasound in case you want to use it for some cases. Okay, so when you take your patient to the theater and you want to anesthetize him, you are going to give a certain medication, and these medications need to be measured, like the effect of this medication, and we need the tools to tell you, is patient receiving the right dose? Is he responding? Is he anesthetized well? When you prepare to extubate him and to send him to recovery, can you send him safely, like to extubate and send him without any residual effect in his body? When the surgeon telling you, for example, I'm going to close within 10 minutes, are you ready by patient out? Let us see. Can you click from your side, please? I don't know, it's not working. Can you click next? Okay, so we have the tools in GE. For example, when it comes to unconsciousness and amnesia, we have clinical measurements and parameter. We call it entropy. So entropy simply, it will tell you about level of hypnosis. Either you are using the gases or you are using IV hypnotics agent. So the parameter, it will tell you if the patient sleeping well, or he's awake, or he's going to recall an event after the surgery. When it comes to pain monitoring and anterosurgical surgical plate index, so while you are administering the painkillers or the pain, managing the pain for your patient, it will give you an indication, it will give you a number, and it will tell you as an indicator if the patient is receiving the right dose of the analgesia. When it comes to immobility, we have the neuromuscular transmitter. It's a module where you can assess the effect of an MPS, and you have the freedom to choose the mode of stimulation, brain for double pace, single twitch, post-tetanic count, and the monitor will notify you if you decide like 2 counts is the recovery and you can top up during the case. In addition to that, the hemodynamics and autonomic stability being monitored, and you have a full parameter and clinical measurements giving you an indication what's happening with your patient. Okay, I like anesthesiologists a lot. Why? Because they make a very nice cocktail of drugs and they administer it to their patient. they take them into a journey. They go like, 30, 40,000 feet, and then they land safely. An anesthesiologist in UAE, he told me a joke. He said, I'm the best drug dealer. I said, why? He said, I make a cocktail, no one else can make it. I can administer it to my patient, and safely I can bring him back to the land. Like, we talk off, then we land safely. And I deal with them. So, the tools we have, it's not only telling you, for example, the effect of the muscle relaxant or the pain or the single medication. It will show you the synergy between these medications, because some of them, as you know, that they have a minor effect and major effect in certain aspect in anesthesia. So, sorry for that. Okay, so what do we have in our monitor? Again, anesthesiologist, he told me this is my radar. Why? As you can see, this is your screen. He said, anesthesia machine with monitor is my cockpit. During induction, this is taxi, then take off, soaring, then landing. So I need a radar. So what does the monitor will give you here? It will give you a kind of radar. It's a dot moving, taking information from the entropy, which is for hypnosis, from relaxation, immobility, and MT, from pain monitoring, STI, and it gathers it in one view, the balanced view, where the dot is moving and dynamic, telling you where was the patient and where he's heading. And your input here is to make it in the middle, like to adjust your medication, either the gases or the right dose. If we look at, okay, so here before the starting, when you start the induction, so you have the tools. For example, entropy, patient awake, so he's 90 and above. An MT, if you are using train 4, there will be 4 counts, 90 and above. SPI, if we put it on for the pain, it's 90 and above. So we are using the same criteria here. You start your induction, for example, entropy at a certain stage, telling you this is, okay, telling you this is a good time for intubation. During the case again, you have the same parameters here, and you can see how is the patient is behaving. If you want to give a top-up, and you can administer the needed dose for your patient. When you want to prepare him for extubation, so entropy again will go back to 90, he's awake, cooperative, and MT 4 counts, train 490 and above. You can extubate him, you can take the tube, he can breathe by his own, and you can send him to recovery free of pain, like SPI is 30. In the previous lecture, the doctor, she said about the palliative with the cancer patient, you need to start inside OR during the surgery to make sure they are pain-free when you send them to recovery. So here is the target zone, and this will guide you and telling you what you can do and how you can manage your patient. Okay, the important thing is that we talk about modularity. So there is no standalone devices. All of these modules plugged into your monitor, and you can have one reading and you can have one screen. All data is there, even for follow-up and studies if you want to do. There is many papers and white papers done by clinicians showing the patient safety, the cost effectiveness, and the better utilization of OR. It's available on our website, the clinical view. And we would like to invite you to our booth. We are sitting outside. We can discuss with you adequacy of anesthesia, low flow anesthesia, and line recruitment. Okay, so I'll stop here if you have any question, because I think I finished the time given to me. Any question from your side?
Thank you so much. Because we're behind with time. All questions should be directed to them at the stands. They have their stands out there, so we can, if we have any questions for them, please go see them at their stands. Thank you. So we'll be moving to the next session of abstract presentations. And this is session 5. It's regional anesthesia / pediatric regional anesthesia and safety. The chairpersons for this session are Dr. Eden Nehemiah and Professor Sadiq Adamu, and to be moderated by Drs. Adeyemi Williams, Dr. Ifeanyi Agadi, Dr. Nkechi Okoje. So please, let's have the presenters for this session. Dr. Wsfa, Dr. Abdullahi M. Dr. Mahdi, Dr. Hajara. Dr. Hajara here. Dr. Hajara, please. Dr. Ashinabi. Dr. Ashinabi. Dr. Irene Ihedeno. Okay. Dr. Hajara, Dr. Ashinabi, Dr. Irene Ihedeno. Please, could you come forward for your presentation? Professor Sadiq Adamu. So Dr. Nehemiah. So Nehemiah. So just to establish a few ground rules, you have 8 minutes to present, and we will give you a warning at the 6th minute, so you know how much time you have left, and then you'll be assessed by the moderators, and at the end they'll inform us of the best presentation. So without wasting much time, we'll start with Dr. Wsfa. Okay. Dr. Wsfa will be talking to us this morning about patient safety culture in the operating room, a cross-sectional study using the hospital survey on patient safety culture. Thank you. Okay, my apologies. Apparently, we need to sort out Dr. Wsfa's slides. So while we're doing that, we'll move to Dr. Hajara, and Dr. Hajara will be speaking to us this morning about comparative analgesic efficacy and safety of epidural plain bupivacaine.
Are you good?
0.5% with tramadol as an additive in lower limb orthopedic surgeries. Thank you. So, you're welcome.
Good morning. My name is Dr. Hajara Aminukalai, my senior registrar with the Department of Anesthesia, Federal Teaching Hospital, Bombay. I'm presenting comparative analgesic efficacy and safety. Comparative analgesic efficacy and safety of epidural plain bupivacaine 0.5% alone and epidural plain bupivacaine 0.5% with tramadol as an additive in lower limb orthopedic surgeries. Epidural anesthesia implies the deposition of local anesthetic agent with or without an additive into the epidural space, which results in the autonomic sensory and motor blockade. The tramadol, a centrally acting opioid-like drug with analgesic effect and fewer side effects than the typical opioid, has been administered through various routes, including the epidural route. Tramadol, when introduced into the epidural space, transverses into the subarachnoid space through the intravertebral foramina. The need for the preservative-free tramadol for intrathecal or epidural use is essential. The lipophilic opioids rapidly transverses the dura where they are sequestered into the epidural fan and enter into the circulation. There are various additive drugs that have been added to bupivacaine to modify its action and to improve the efficacy of neuroaxial regional anesthesia. This includes, amongst others, opioids like tramadol, morphine, and fentanyl, as I mentioned earlier, preservative-free. NMDA antagonists like ketamine or magnesium, GABA agonists like midazolam, adrenergic agonists like clonidine, adrenaline, and anticholinesterases like neostigmine and cyclooxygenase inhibitors like ketorolac. This study was aimed at comparing the analgesic efficacy and safety of epidural plain bupivacaine 0.5% alone and epidural plain bupivacaine 0.5% with tramadol as an additive in the lower limb orthopedic surgeries. The objective of the study was to determine and compare the duration and quality of